All right, good morning, everyone. My name is Zach Kacharski. I'm the executive editor at the Gazette, and you are joining a panel that is focused on cancer in Iowa. Obviously, that is something that touches nearly everyone in the state in a variety of ways. I'd like to thank our presenting sponsor, ITC Midwest, and I'd like to introduce our panelists. Joining this morning, Mary Charlton is an associate professor of epidemiology at the University of Iowa. She's also the director and principal investigator of the Iowa Cancer Registry. Dr. Ann Stroh is a medical oncologist at the Mercy Medical Center, Hall Perrine Cancer Center in Cedar Rapids. And joining the newest member, I guess, of the Iowa community is Dr. Mark Burkhardt, and he is the University of Iowa Healthcare Holden Comprehensive Center director, and is also a professor of internal medicine at the Carver College of Medicine at the University of Iowa. I'd like to welcome each of you to the panel this morning, and thank you for doing this. Before we get going, if you have questions, you can submit them as we get going. I will work them into the conversation. And also, we are recording this conversation, and the replay will be available early next week on the iowaideas.com website. But Mary, maybe get started with you a little bit. If you want to give a little bit of an introduction, how you got into working with the cancer registry, what drew you to the work, and some of the context of that.
Sure. Well, like you said, I'm a professor in the Department of Epidemiology. I started my education with a nursing degree, actually. And when I learned what epidemiology was, which took a little while, I thought it sounded like something that would really make use of a clinical degree. And I just really enjoyed it and worked a lot with Chuck Lynch, who's the former PI and director of the Iowa Cancer Registry. He got me really interested in cancer epidemiology. So I continued on after my master's. I worked at Wellmark Blue Cross Blue Shield for about 5 years and really learned about the healthcare system in Iowa from that perspective. And then came back to academia as a professor in epidemiology and took over the Iowa Cancer Registry a few years ago when Chuck retired.
All right. Dr. Stroh.
Hi, yes. So I am an Iowa girl through and through. I was raised in Iowa on a farm in Western Iowa, did all of my training here. I left the state for about 7 years at the University of Colorado as director of breast cancer, but wanted to come home and finish raising my kids in Iowa. So medical oncology has always been so close to my heart. I love to get to know my patients and to spend time with them and want to make cancer care better in our state.
All right, thank you. Dr. Burkhardt.
Hi, thanks for having me here. I'm Mark Burkhardt. I'm, as you said, the new Comprehensive Cancer Center Director as of October 1st, so very fresh. I trained and I'm from New York State originally, and then have been at the University of Wisconsin for 16 years before joining the University of Iowa. And I'm a scientist. I'm interested in cancer research, but I also have been active directly in taking care of patients as a breast cancer focused medical oncologist. So I'm very pleased to be here today.
Right. Well, thank you. And look forward to the conversation. There's a lot to get to, and this is probably one of those sessions that could last about 3 hours, but we'll get to as much as we can. And I think a level setting question that I would have is, as we come together today, Iowa has the second highest incidence for cancer in the country. An estimated 21,000 Iowans will be diagnosed with a new cancer this year, and roughly 6,100 Iowans are projected to die from cancer this year. I'm curious, as we sit here and kind of kick off the conversation, what has you most concerned and most optimistic of the current state of your treatment, as well as just the landscape in Iowa?
I guess, oh, go ahead.
No, go ahead, Dr. Burkhardt.
Obviously being number two and the cancer registry and Mary have done a lot of work, but obviously being number two is not where we want to be. What gives us a nugget of hope is our mortality rates are not as high. So clearly we're doing something once we find the cancers, but we need to really dig deeply into looking at the root causes. And I think Mary, Dr. Charlton can really speak to some of the efforts to do that. But a lot of it is taking the known risk factors of cancer and getting the message out to the whole state of what those factors are, how they apply in the communities, and the things that are within our control. Unfortunately, in cancer, there's some things that are not in our direct control. We're humans. We're made up of cells. Cells have genes. Genes change over time, and there's some cancer risk that just emerges over time, just being a human. But those things are everywhere in the world, and being number two means there's some risk factors here that we need to work on that are pushing those rates up.
Agreed. I think one of the biggest things is just lifestyle here in the state. We have a very large obesity rate. There is a lot of chemicals that we're exposed to. Growing up on a farm ever since I was 2, I've been exposed to those chemicals. And I think trying to figure out ways to make it a healthier environment and get education to patients on how to alter the things we can alter, and work on getting ourselves healthier.
Yeah, I agree with all of that. I think another concerning thing is that our rates continue to increase. Our age-adjusted rates are on the rise while the rest of the US is stable or declining. So that's another concerning thing. And this is the third sort of reporting period in a row where we've been one of the only states with a rising cancer incidence. So that's concerning. I think optimistically, though, people are talking about it now more than they ever have been before. And I think there's some momentum and some will, I think, in the community to really do something about our high cancer burden and try and figure it out.
Mm-hmm.
Dr. Charlton, maybe staying with you, when the Cancer Registry released the annual report this year, you also chose to focus on alcohol and the consumption of alcohol and its ties to cancer. I'm curious why that decision was that made as kind of something that could have the biggest impact. Why did you choose to start with that highlight this year?
Sure. Well, just as context, we've been producing the Cancer in Iowa report for a little over 30 years now. And in each of those reports, we feature a specific cancer type, an exposure, or a subpopulation to build awareness among Iowans. This past year, we chose to feature alcohol because Iowa has one of the highest rates of binge drinking in the country. We're now number 3. And because studies have shown that the majority of Americans do not know that alcohol is a carcinogen and contributes to the development of cancer in several ways. The report got the most exposure it ever had before, which was great, and the feedback was overwhelmingly positive. I heard from countless people that they never knew alcohol could cause cancer and had been long confused about the mixed messages from public health around the benefits and harms of alcohol. But because many people were reading the Cancer in Iowa report for the first time, I think many interpreted it as us suggesting that alcohol was the main driver of high cancer rates in Iowa. We specified in the report and in every interview and presentation we've done since that we think alcohol is one of many factors that drives our high cancer rates in Iowa. I think of cancer like the old Trivial Pursuit game, with the different pieces of the pie. And as Dr. Burkhardt said, some of those pieces of the pie get filled in for you. Some of those risk factors like your genetic family history, your race, your age, as you age. But the rest of it, like for the rest of the pie, we're trying not to fill in the pieces. We're trying not to fill in all the other lifestyle and environmental type of risk factors that we can that are under our control. And I think alcohol is one of those pieces of the pie that's really important, and it's a very wide exposure here in Iowa. So that's why we chose to feature it.
Dr. Shore, you mentioned kind of the lifestyle choices, and this is something that has to be done along the way, but those are not easy conversations to deliver, and you're doing that usually one-on-one. What do you hope that people maybe adjust their thinking in terms of heeding that the lifestyle?
Yeah, and it is challenging. And so we currently have a high risk breast cancer program where we take women who have a greater than 20% lifetime risk. and following them closer and work with monitoring them and try to help with lifestyle changes. So we have incorporated a dietitian. I think telling patients it's little bits at a time. I think if you think of completely revamping your diet and exercise can be overwhelming, but it's starting with one thing. We have a great exercise program and team with physical therapists that are working. We're partnered with the Y to give people free memberships for a certain time. So to kind of really get the education out to the patients that this is important. The important piece is the pie, like Dr. Charlton said.
How long does it take? I mean, with some of this messaging, how long do you expect it to take before you can start to see uh, uh, results? There are lots of different levers. Lots. I mean, is this kind of the entry point to a broader conversation in the state, and then you can work to have more nuanced, focused conversations, or
Yeah, I think, where it starts a lot is with our youth, number one, working with them. But I always tell the adults it's not too late to make modifications to help with things, stopping drinking, stopping smoking, watching what they're exposed to, whether eating organic, not organic, what people think with that, eating fresh fruits and vegetables. So it's going to take a while for this shift to happen with our older population. But I think that's one thing we got to get access to the younger folks to help with these, to help it move along. But it's not going to be an overnight thing.
I was curious, Dr. Charlton, maybe you can talk a little bit about this, but when you're doing the surveillance and kind of collecting the information, how does that happen? Um, how manual is that process? How automated is that process? How are you getting the information to kind of get an accurate picture?
Sure. It's fairly manual, but it's getting more on electronic and sort of automated to the extent possible as we go along. But we're collecting hundreds of variables on every cancer patient in Iowa, and those variables differ by the different cancer types. So it's very complicated. Each of our largest cancer centers in Iowa, or ones that are accredited by the Commission on Cancer, which is the kind of the accrediting body of cancer centers, they all have their own hospital cancer registries. And so those registries they're in the hospital and they're collecting the data and they send it to us at the state. Then we have abstractors at the state then that work with all the other 108 hospitals in the state to collect that information on their behalf. So we can remote into most of those medical records. And so it's less of, we used to have people stationed around the state to go flipping through paper charts and things like that. So it's a lot more streamlined now, but it's still very manual because it takes a lot of human judgment still to kind of look at all the notes. And people in Iowa, they go to more than one place. I'm sure Dr. Stroh and Burkhardt know the routine that people, especially in rural Iowa, might have a colonoscopy at their local small hospital. Their cancer's diagnosed there. They're then kind of sent on to the next place, maybe an hour away, where they might be able to get chemo and radiation, but they might have to go to the university or somewhere in Des Moines for their specialized surgery. And so they're coming to all these different places. And so the magic of our statewide central registry is to consolidate all that information and get the best information per person per cancer, so that researchers and public health practitioners can use that data to help reduce the burden of cancer.
And can you talk a little bit about how it is used on the research side? What are folks looking for? How detailed? How long of a span are you looking at when some of those research projects are happening?
Yeah, I mean, we're really fortunate here in Iowa to be part of the National Cancer Institute's SEER program, Surveillance, Epidemiology, and End Results program, which started out as 9 registries that they could then use to project and estimate the cancer incidence across the country, cancer incidence and mortality. So we were one of those original members since 1973. Since then, all states now have cancer registries that can report the data, but we have a lot of great resources because we're housed at the university. We have great expertise and resources. So we're not just collecting the data, but we're using it all the time in research. And then we also pass up de-identified data to the NCI. And so there's a database that researchers all over the world use. They publish thousands of papers from the SEER registry data. We're involved in countless research studies, one of which is called the Agricultural Health Study, run out of the National Cancer Institute, where they enrolled 50,000 pesticide applicators in Iowa back in the 90s. And so they've studied them extensively, and they link to our data to get cancer as an outcome so that they can look at some of those things driving outcomes. So we participate in countless studies, and then we do our own research here and have very active research portfolio in conjunction with the Holding Comprehensive Cancer Center. So we use it in every way possible.
And just to add to what Mary said, one of the missions of the Cancer Center in serving the state is to use this information to establish priorities in our research. And this goes into all kinds of research programs. What are our priorities for clinical research? What are our priorities for basic research? And what we learned is that we should prioritize melanoma, breast cancer, lung cancer, and prostate cancer as the priority cancers. But also that we should, look into root causes beyond the big ones we know about: alcohol, tobacco, UV light, radon, and obesity. Are there other things going on? And as Mary said, we are actively looking into other possible explanations. But we're trying to get the word out about those big ones that we, lumped under the category of lifestyle that we know we should act on now, both from getting the message out and promoting this individually, but also what are the policies that and health system things that could be done systematically to promote health in the population.
I'm curious, when you talk about establishing those priorities, how does that discussion happen? Because you're working across a lot of different groups, and how does that discussion of, as medical professionals in Iowa, we should focus on this. How do you establish kind of those shared priorities?
I would say Dr. Charlton is one of the leaders in the Cancer Center. And so we hear frequently from her work, the work in the College of Public Health, and get a lot of feedback. And one of the priorities of the Cancer Center is to take that and invest. And you're right, we'd like to push that information out to the state. And Mary and others have ways of reaching to populations. Our Cancer Center clinical programs and laboratories focus on more the active research of those areas of cancer. But I think Mary could probably speak more to the population health activities.
Yeah, I mean, we looked closely at, why are we increasing where other states are decreasing? What is driving that? So methodologically, we figured, like, what if we subtracted certain types of cancers, which ones would we have to subtract before we get flat, like at least flat, if not decreasing? And that's where we came up with the ones that Dr. Burkhardt mentioned, which is lung cancer. Iowa's made one of the slowest progress in decreasing their lung cancer rates in the country. It's declining, but barely, and not nearly as quickly as in other states. Melanoma is just really increasing. We have a very similar rate of melanoma to Arizona and some of the other Sunbelt states here in Iowa. Breast cancer is one of our huge drivers of our trends. And we have a very much increasing rate that's increasing faster than other states in the country, and same with prostate cancer. And those are some big cancers. Colorectal cancer we're also high in, but that's declining at a slope that's very similar to the rest of the country. So we try to focus on like 4 big ones that impact a lot of Iowans and where our trends are just off from the rest of the country. And that's where we think you get a lot of bang for your buck to focus on the factors driving those, and also making sure we can care for all those people. Those are really high case count cancers.
When you identify kind of those priorities, when you mention, lung cancer and melanoma, that things, how long does it take to kind of do the research to start to figure out a strategy? This is not something that, is a 1-year type of thing, correct?
Correct. Yeah. So, I mean, it's something we constantly look at. Another in partnership with Iowa Health and Human Services, we're going to work on, really zooming in on some geographic patterns. That's kind of another way that I can, assure people it's not one thing driving the cancer in Iowa. every cancer has a different geographic pattern that I think depending on the risk factors and the sort of context of that area of the state. So we're doing a lot with that and really digging into the 4 cancers that we mentioned to try and figure out, what are the what are the factors unique to Iowa that might be driving those. So as you said, it's a long process, and it's very unsatisfying to know it'll be a long time before we know if we made an impact, because cancer, doesn't develop overnight. It sometimes takes decades. So it's kind of a slow slog.
One of the other questions, I'm sorry.
I was just going to add to what Mary's saying, that even though what we do today, or what we start to do, is going to take a while to turn around rates because of the latency of cancer, we can do things today. We know a lot about risk factors for cancer, and we know which of those pieces, as Mary said, are modifiable and which ones are sort of fixed and outside of our control. And to be fair, the risk factors we know the most about are the big ones. They're hard to miss because they change the risk of cancer so much. You can clearly see a difference between the people who are exposed and not exposed pretty easily. So that's why it was so easy more than 50 years ago. If you really look at the data, we knew lung cancer was caused by tobacco. I mean, it was pretty clear because the signal was so great. So we can work on those things that might have a smaller signal, but we should immediately promote policies and behaviors that reduce those bigger risks. And that would have the biggest impact today. If we could reduce smoking, tobacco use, if we could reduce binge drinking and alcohol use, if we could reduce exposure to UV lights and use sunscreen covering, those will have the biggest impact in the near future.
I'll jump into the policy question in a couple minutes here, but I also wanted to just ask, how complete, do you feel that the picture is? Are people getting screened, taking advantage of some of the preemptive things, and how complete do you think the data set that you're working with is? And would efforts on that front assist as well?
I think in terms of capturing cancer cases, I think it's fairly complete. I might be a little biased as they run the registry, but we continually deploy efforts to make sure that we're getting all our cases. There's a lot of mathematical modeling that goes into NCI saying this is how many we expect you should have, and we always hit that. So I think it's pretty about as complete as any surveillance system for any illness can be. I think cancer is sort of the utopian system of surveillance because of all the resources that it gets. I think we do fairly well in screening in Iowa. A lot of people have asked, are we just getting better at screening? And so that's why our cancer rates are increasing, because we're finding more. We do well in screening for the most part, with one exception that I can talk about, but our screening rates are not going up proportionally to the way our cancer cases are going up. So for example, our mammography rate is very stable at around 80%. It's not moving up as our cancer incidence is moving up. Our colorectal cancer screening rate is around 75%, which, I think the goal is to get it closer to 80, but that's pretty good. Pap testing is over 75%, which is good. Lung cancer screening is one that, that's a great opportunity for every state. We're not even that bad at it, but we only have about, I think, 7% of eligible cases getting lung cancer screening. Not to say that number should be 100, but it should probably be a lot more than 7%. And that's one where, that can have a huge difference. If you can find lung cancer early stage, you actually can treat that fairly effectively, and people can live a longer quality life. Whereas if it's caught in later stages, the survival rate is very poor.
One of the questions that has been submitted from the audience is that there are environmental factors such as water quality and things. Dr. Stroh, I think you mentioned the chemicals that are applied. How might some of that play a factor in the cancer rate? To what extent does that play in?
I think it probably plays a big factor. I think it's hard to track that because you can't, I mean, modifiable risk factors when you talk about alcohol use, smoking use, you don't know what you're getting exposed to day in the environment, and that's hard to track. But living in an agricultural community and especially growing up on a farm, we were exposed to chemicals all the time. And so I think that has a huge impact when you just look at the rates of our cancer. I think that's big. So we need to find alternative ways to help with less toxic chemicals.
All right. Um, One of the questions, and Dr. Burkhardt, you kind of touched on this, is the policy standpoint. How do you approach that? And what are the types of things? What is the kind of that entry point that you start with, and what are the most important things?
Well, again, I think the number one risk factor for cancer, if you look at the risk proportion, is tobacco, and that's where we're going to have the biggest impact. So any policies that would reduce the use of tobacco, increasing tax, reducing the number of places that sell tobacco in a county, anything to promote tobacco cessation in terms of helping people reach a quit line and get training and help with quitting. I think what people don't realize with tobacco risk, we all know it causes lung cancer, but I think people kind of miss that it has a big role in other cancers too. Head and neck cancer, bladder cancer, and several others. So, that is our low-hanging fruit. And if we could have a big impact on that, we would save a lot of lives.
And we used to have a really robust program with Quitline Iowa here, but it lost funding. So now with patients, we used to be able to turn them over and get help with medication, help with counseling, and provide resources for the patient. Now we still have some of that, but it's not like what it used to be. So that would be a big, huge policy change to get those back available for our patients.
Yeah, I agree. I think the public health evidence would say that the single biggest, most effective change that we could make in Iowa is to raise the tobacco tax by over $1. That is hands down been shown to be the most effective in reducing smoking rates, which in turn is the most effective in reducing lung cancer incidence. Lung cancer accounts for 25% of all of our cancer deaths here in Iowa. So, if you had to pick one thing, I think that I agree that would be the thing. But we need to address a lot of things, not just that. And policy wise, melanoma tends to be more common in Iowa in older men, but there's one age group, females have the higher rate, and that's younger females. And Iowa continues to be one of the only states that has no restrictions on minors using tanning beds. So there's lots of things like that. The Iowa Cancer Plan that's put out by the Iowa Cancer Consortium has a whole host of really comprehensive policy recommendations on the community and state level to really address a lot of these. And I think we need to, I know we need to start somewhere. So I agree that the smoking is the place to start, but I think to really make a difference, we're going to have to impact a lot of these risk factors that we're really high in.
We had another question from the audience that, how do you think access to healthcare in Iowa impacts cancer care? And to what concern? Obviously, there's a major announcement this week that maybe there's more of a system on the way in. But how big of a concern is the healthcare desert and the access to family practice physicians in terms of cancer care?
I think it's huge. We struggle significantly getting patients in to be seen with lack of primary care. And especially as we go out into the smaller communities that are around Cedar Rapids. And we also struggle getting patients to larger tertiary centers that we just don't have. If we need GI, it takes 6 to 8 months to get in to get a scope. So I think we're lacking in specialty services too for a lot of these patients to get the screening and get the appropriate care. And I think it's a big issue here in the state of Iowa.
I mean, to add to that, we have an aging population in this country and in this state. And so cancer, risk goes up with age. And so our number of cases are going to go up there. But we're a little bit victim of our own successes in that people with incurable lung cancer and incurable melanoma are now what we thought was incurable melanoma are sometimes having their disease controlled for years instead of losing their life to cancer because of the improvement of treatments over the past 10 years. So all of those patients need continual care with physicians, specialty physicians. And so that success, ironically, the number of survivors we have has made it harder to provide access to others. And we've all had to grow our oncology practices and our care delivery models. The other thing that's changing, because cancer is a fast changing field, is delivering care has gotten more complex. Our guidelines used to be a few pages for each type of cancer. I pulled our breast cancer practice guidelines, the national standard of care, and it's over 230 pages of arrow diagrams and footnotes. And so we're in a world where if you are disconnected from the cancer community, it's hard to effectively practice. And so at the university, what we aim to do is to have a footprint where we collaborate at many sites around the state and provide support and expertise and referral for very specialized treatments like cellular therapies that are hard to deliver because they're so specialized. And so the announcement this week was the teaming up with Mission Cancer and Blood in Des Moines, which will help us deliver our care to the entire state. Mission and Cancer Blood is a 40-year-old patient-centered practice that is very effective at delivering cutting-edge cancer care. It has 20 outreach sites around Western Iowa. And by teaming up with them, we will allow patients in any community hours away to have access to the specialty care and backup here at the university. So I think this is a great opportunity to deliver better care and provide access. There's still a lot of work to be done, but I think this is a very positive direction.
You mentioned, I kind of want to follow up on that idea of developing a care plan. How has that changed? And in terms of if you're having to think about 230 pages of options, and I mean you're not doing that. Well, hopefully not doing. No doctor is doing that at the bedside. But how do you keep abreast of the things that are working, and also really look at all of the variables that could be in play?
Well, I think one of the things you do is specialize. You have experts who are very focused on specific diseases, like Dr. Stroh and I focus on breast cancer. It's a little more manageable if we do that. But the traditional oncology practice, especially in communities around the state, is you have a general oncologist who's responsible for every type of cancer. And now you have that level of complexity with each specific type. And it's overwhelming. And so what you need to do is you need to have those physicians in the community connected with experts who can help them and back them up and provide support and provide specialty tumor boards and get a pathologist who's very specialized to support that. So that's why having networks are important. The world has changed in oncology. It's gotten too complex to operate independently as a physician, general cancer doctor in the community.
Dr. Shore, you also mentioned this, some of the screens and the difficulty there of the wait times for some of those pieces of information. How do you go about improving that?
It's a struggle, and we work on it quite frequently here in our system. It's getting more providers here to the state. I think that's a huge thing, is that, it's hard to recruit doctors to Iowa. And we've got to find incentives to get them here, especially the specialists that we need. And it helps when you're born here, when you've lived here all your life, to stay in Iowa, but to try to get an East Coaster or a West Coaster to come to Iowa. And I think it's collaborating. We have started multidisciplinary teams here at our clinic, just to try to get the screening, get it out, doing a lot of public education about screening. I think it's huge with the patients, and let them use their voice to get out to help get access to that.
Dr. Burkhardt, I kind of wanted to bring in, well, you're new to Iowa. You've been involved in the research consortium that Iowa has with some of the other Big Ten universities. Can you talk a little bit about, it's not just Iowa, but what is that consortium doing, and how does that help, in Iowa?
Well, we all know about the Big Ten sports and enjoy the Hawkeyes game. I'm going to my first one in person in 2 days, so I'm excited about that. But the Big Ten also is, if you look at the universities, there's a large group of very active cancer research centers that are NCI designated at most of them. And with this expansion to the new Big Ten teams, we've also reached out to the West Coast Big Ten sites now. For example, University of Washington, their football team's coming in 2 days. They were at our most recent summit in Chicago a couple weeks ago. What we're doing as a Big Ten network is we're collaborating on research. And what the Big Ten brings is sort of a demographic population that really represents the whole country well. There's a lot of rural populations that we bring. There's a lot of urban populations that Northwestern and Ohio State will bring, for example. And we do clinical research mostly. We bring clinical trials, collaborating to advance the care. A number of clinical trials have successfully completed and have changed our knowledge of how to treat cancers. So it's a way of taking, sort of the competition on the football field and the other sports fields and bringing them to a collaborative place where we can work together to make cancer better.
And in terms of Holden's contribution, what are you hoping to see in your time as director? Where do you want to take it?
What I'm hoping to see is collaboration at all levels across these major cancer centers. Right now, we have good collaborations on clinical trials, as I discussed, but we're looking for other levels of collaboration on population health science, on working on symptom management, all the other components, survivorship, all the other components of what a comprehensive cancer center does. We're trying to make sure we can collaborate on those things as well. So that's what I'd like to see.
One of the aspects, and Dr. Charlton, maybe from your time at Wellmark and Dr. Stroh, affordability of care is also one of the questions. How big of a factor is that in terms of the quality of the testing or the screening that's happening, in terms of patients having access to the testing that they need? What is the current state, and what needs to be done on that front?
It's a big struggle. With our, we're really struggling right now with insurers in the state with letting us do exams. So say a PET scan, our use of PET scans have gone down 20 to 30% because the insurance companies have hired these third party vendors to negotiate whether we can get the testing done or not. So we're struggling along those lines. MRIs for women with breast cancer, we'll get denials for that all the time. And women don't want to spend money, the $3,000, $4,000 to get the MRI. Fortunately, we have a resource here in our community that helps these women, but when they're dense, when the density, they need better testing. And so women can't afford to pay that type of money. And we're really struggling with the insurance companies too, with covering these services for our patients.
I think it's a struggle too on the prevention and screening side for people, for sure. And also, we see things like, rural and urban populations in Iowa have a very similar cancer incidence rate. Actually, the rates are increasing in urban areas a little faster than they are in rural areas, but they're pretty comparable. But we see that the mortality rate is worse among our rural population. And that could be, finding cancer at later stages. It could be that they have a real struggle getting to care. Even things like colonoscopy, you have to take a day off work. You have to have somebody to drive you. If you live far away and you don't have the type of job that's, you can just finish when you get back or someone else can do while you're gone, which is a lot of rural areas with farmers or people who are self-employed, who don't have their insurance through a large employer. That's extra challenges to be able to do that. And again, having to travel pretty far sometimes for specialized care can be really difficult for patients to have access. And I think that the transportation barriers are really tough. And, in the cities we have Uber and different things we can use, but there's not much to get you between towns in Iowa. That's a real struggle, I think, for people.
Yeah, we cover over, we have patients coming an hour or 2 hours away, and that does play into effect what treatments we offer. If it's going to take them, what can they afford? I mean, we think of the healthcare itself, but you think about what does it cost for gas? What does it cost to be away from work for several days? I mean, those are also huge impacts. And I think it really impacts our rural state, if they have to travel quite a distance, which they do.
It's you start to think about the complexity of that and just the number of factors, and so it'll be interesting to see as the conversation progresses how you get some of those wraparound entities at the table, that are maybe a little bit outside of just the medical community. I wanted to talk, Dr. Charlton, you mentioned, sorry, my lights in the office disappear and then I disappear. You had mentioned, some of the differences in rates in different places around the state. And I'm curious, are there pockets of concern in terms of demographics or geographical, areas of concern that you're seeing?
Yeah, I think for sure. I think in terms of some urban areas, Iowa, while as Dr. Burkhardt said, we're kind of average for mortality rate, which is great. We actually have the second highest mortality rate among our Black population in the state. And we have one of the widest gaps between white and Black mortality in Iowa, preceded only by Wisconsin, actually, where Dr. Burkhardt was coming. And DC, but we're consistently in that spot. Waterloo tends to be, or still is, considered one of the most segregated cities in America. And we see some of the biggest disparities between that zip code that's about a third of Black residents versus just, the West Side or Cedar Falls. Huge differences in risk for things like lung cancer. So I think we have a lot of work to do in figuring that out and figuring out what to do about that. That's a huge concern. I think in terms of, and it's not totally unique to Waterloo, but I just use that as an example. I think in terms of rural areas, we see in southern lung cancer incidence and mortality tends to be high in the southern kind of tiers of counties of our state, and that's where we see the highest smoking rates. I'm not sure about their radon exposure, but our whole state sits on the dirt and limestone that produces it. And, it may be that they have less testing and mitigation down there. That could be a factor. There could be a lot of factors driving that, and access to care. That's a tough place in Iowa, in that south part. I don't think there's a lot in northern Missouri to help them out. So I think they have to drive north to get care. So I think people living along the river, the Mississippi River, we tend to see some high cancer rates, and that, it kind of depends on the cancer type where we see it, but there's definitely pockets around the state. And those are the kind of the ones we're trying to dig into a little bit more and figure out what's going on.
A clarifying question that I wanted to ask: when you talk about smoking, are you also including vaping in that um,
I am
concern?
not, because
Okay.
I'm kind of quoting the behavioral risk factor surveillance system, which is specific to tobacco. And we currently still have 15% of our population smoking, which isn't the worst, but it's certainly not the best, and it leaves a lot of room for improvement. I think vaping is a little more unclear about its actual risk, direct risk for cancer. I think anytime you're inhaling something, I think there's going to be a risk, but I think it's not as great as tobacco. But I will let the clinicians maybe weigh in on that.
I think there's concern about other risks of inhaling the vehicle that the nicotine is dissolved in over many years. We don't have long-term follow-up. We know what happens to people who smoke for 20, 30, 40 years. That data is not yet available with vaping. So we have to be really cautious about that. It seems like the cancer risk there will be lower, but there could be all kinds of other health risks about pulmonary disease over the long term.
Yeah, you don't know the
And
effect of COPD
I'm
or
sorry.
yeah, what's going to affect the lungs, the COPD, emphysema, that lung.
Right. So it's hard to recommend it, but probably the risk of cancer is less than smoking tobacco.
And I certainly didn't want to imply that I was recommending it. It was just a clarifying
Right.
question. Um,
Well, I
it,
was not giving it as an alternative to smoking, as
yeah,
a healthful alternative, let's say. I was
no.
trying to make that distinction.
No, I certainly I understand. I wanted to talk a little bit about Dr. Stroh. Obviously, delivering a diagnosis can be one of the most difficult things. Uh, how do you approach that? And that's potentially devastating news. How do you approach that in a way that the patient feels heard, and how do you kind of approach the uniqueness of each personality?
Sure. And that's the art of medicine. I always want patients to understand that they're in control. So, one of the first things that happens with patients is they feel like they've lost control. They've got a cancer diagnosis, everything's kind of whirling and swirling. And so, okay, let's stay organized. Let's figure out what our plan is going to be. How are we going to attack this? And I think meeting patients for where they're at, what are their social issues? Do they have to drive a long period of time? With a lot of my patients, is it easier to take an oral pill if you're going to be living 2 hours away? Something given on a weekly basis may be more challenging, but it's hard to deliver the news. But I think having compassion with patients and going through this in my own family with relatives, I think has put me on the other side to help patients understand it better. But I think it's just listening to the patients so that they know that they're heard.
Dr. Burkhardt, I know obviously you're working with students. How do you uh, coach that?
Well, that's that so when we work with students, like medical students, there's sort of a description of how to do it, but I think a lot of it is modeling. I think I as a student and as a trainee worked with many physicians and was part of discussions with them and their patients, and so you learn kind of what you like to model and what might not be the best approach when the communication isn't strong. So and then what we often do is have our learners practice. So as medical students, often we have actors who come in and act as patients and do that in a sort of a controlled environment. And then later in the training, when we train medical oncology fellows, we often say, would you permit Dr. So-and-so to do the discussion of what this means? And many patients will say yes. And then I will sit and observe their communication and give them feedback. And so those are some of the tools we use to train people on communication.
One of the questions that has come in from the audience is, do you expect the kind of the announcement this week of the systematization it- to lead to more clinical research trial opportunities? I know that there had also been uh, the expansion. There was approval for expanding the Holden Comprehensive or the research facility, but do you
Mhm.
believe that this is going to lead to more clinical research and trials in Iowa?
Absolutely. I think this is going to do that. Mission Cancer and Blood has its own clinical trial portfolio that's very strong. Here at the University of Iowa, we also have a strong portfolio, but that's Iowa City and Des Moines. And what we want to do is combine our forces so that when, a new drug, an exciting drug is developed, instead of the company just partnering with sites in Houston and Chicago and New York, that they want to come to Iowa, that we will give, they will come to us so we can provide access to the most promising new therapies and bring it to Iowa really early. Because right now, what's happening is a lot of our early drugs are showing incredible promise already. 20 years ago when I was training, very few drugs made it through the clinical trial pipeline to being approved. Right now, because we understand more about the biology of cancer and because the technology of developing drugs has improved, I've seen many early phase drugs, like early in development, show great promise. So we want to offer that to folks in Wisconsin or in Iowa. I'm sorry, I'm new here. I'm just just cross the border. But and the way to do that is to combine our forces. So as many patients have access, and then the sponsors want to partner with us because it's easier to have many patients involved in those trials quickly.
Okay. A question from the audience that has come in. How has AI and AI tools assisted in early detection or been implemented in the training of diagnosing cancer? Is this something that you're working with yet at all?
So we're looking into that with breast cancer detection. I think that's kind of where it's got its biggest forefront. Looking at breast density. So we have just at our department got specialized software to start working with that. So AI is really coming to play, but I think it'll be huge, but I think with breast cancer and mammography is where it's at right now. We also are using AI just to help our doctors live better day-to-day lives with dictations, so so we can get out of the clinic and not spend our time in front of charts. So it's coming.
Yeah, there are other areas of screening, lung cancer screening, like reading radiology, helping the radiologist find the important parts of the radiology, as Dr. Stroh said, with mammograms, but also in lung cancer and other cancers. It's helpful for that. And in pathology. So to make a cancer diagnosis, you have to get a biopsy and then look at that under the microscope. But now you can digitize that and analyze that with AI. So that can help make sure the pathology is very consistent. There's a lot of things where if you give it to 100 pathologists, they all agree on. But there are other things where if you give it to 100 pathologists, there's a little bit of nuance. And this promises to help make that more consistent so that pathologists everywhere could, have consistent diagnosis.
Dr. Charlton, is there, in terms of the surveillance, AI coming into play there at this point?
No, I wouldn't say we've capitalized on AI yet. In the surveillance world, we're a few steps behind and still just trying to get electronic pathology systems up and running so that we can get real-time messages as soon as somebody diagnoses cancer. So we're a little behind on that one.
Well, I don't think that that's behind at all. I think that that's incredibly complex. So, I wanted to kind of, as our time together comes to a close, if there was, something that you think is frequently misunderstood, or that you want people to have a better understanding of when it comes to cancer, what would that be?
Yeah, I would say, just from my experience for the last couple of years of fielding questions about our high cancer rates, I think the most misunderstood thing is that there is one thing driving our rates. I'm asked many, many times, is it the pesticides? Is it the nitrates? Is it the water? Is it the smoking? Is it the, what is it, the alcohol? Yeah, I feel like all of the things. It's all of the things. It's not one of the things. There's no way I would see the geographic patterns that we do that are different for each cancer if it were one thing. There is no point source causing cancer in Iowa. We have a mountain of pebbles. We are, like I said, the third highest in binge drinking. I think we have a quarter of our population that do no physical activity whatsoever. I think we have more than a quarter of our population that eat no fruits and vegetables whatsoever. We still have 15% of the people who smoke, and we're 12th in obesity with 37.4% of our population that fall into the category, which is imperfect measurement, but fall into the category of obese. Again, we still have the high melanoma rates. It's all the things. And if we just focus on one thing, with the possible exception of smoking, which would be the first place to start, but we will not see a big reduction in cancer if we just focus on one thing. I think it's easier for people to think that it's something that's being done outside of their control, but there's lots of things we can control, and there's lots of things as a state we can do better and make it easier for people to make the healthy decision and make it harder for them to make the unhealthy decision. And we really haven't done a lot of those. We have not pulled a lot of those levers in the state as others have. And I think that's why we see a widening difference between our cancer incidence and other states.
Just since you had moments of passion there, what levers would you want to see pulled?
I think raising the tobacco tax would be number one. I think putting some restrictions on tanning beds for minors would be another high up one. I think we really have to figure out, especially, I mean, everywhere, but people are very concerned about the pesticides, understandably. Like I do not discount that, and I agree. But the things they put in the food after they pick it, as they are, after they plant it, the high fructose corn syrup, of which we make a lot right here in Iowa, you look at something you buy at a gas station, like one of those baked goods or anything, and it's 75 ingredients in there. I mean, we are eating a ton of processed food. We are not exercising. We are not doing, I mean, we have got to work on, whether it's at the community level, the state level, providers and their patients. We've got to figure out how to help patients make better decisions for their health that are going to not fill in those pieces of the pie, and so that they don't end up with cancer.
And Dr. Stroh and Dr. Burkhardt, in terms of the frequently misunderstood, I'll go back to that question.
I think I reinforce what Dr. Charlton said. It's patients think, okay, I must have done one thing wrong that led me to this point. And it's explaining to patients that there's so many variables. Again, I'm just reiterating what Dr. Charlton said, and that sometimes there is a piece of bad luck that has happened in there, and we don't know why. But it's moving forward and trying to make the changes once they get the diagnosis to have a healthier lifestyle.
Yeah, I agree with that. I've had so many patients come to me and say, why did this happen to me? I distinctly remember a woman who was in her mid-30s. She was an iron man or an iron woman. And she ate a really healthful diet, never smoked, didn't drink. Why did I get breast cancer? And it was an impossible question. There's no risk-free approach. But as we talked about, as Mary nicely said about the pieces of the pie, there are some within our control and some that are not.
All right. Well, I appreciate each of your time today. I know you have many places to be, and to our attendees as well. I appreciate you taking time with us. And so this concludes this bank of sessions, and so the next group will start in about 10 minutes. Thanks, everyone.